Good morning, everyone. I think we're going to go ahead and get started. We were just waiting for people to sort of trickle in and grab breakfast, but we're going to go ahead and get going. Thanks for joining us so early this morning. We've got a very, very full hour, so we're going to get going and take turns giving this presentation in 3 rounds. The title of our talk is Key Challenges Associated with NGS-based Tumor Profiling, Lab, Clinic, and Patient Perspectives. Here are our disclosures. And before I get going into the talk, I thought I would just take a step back for a second and just give you guys a little bit of background about who we are at Personalis. I'm sure there are some of you who've attended prior sessions that we've had at NSGC and other webinars, and most of you probably know us for some of the clinical exome sequencing that we do, but we also, in our company, have a really big research arm where we do a number of research testing for translational research, clinical trials, and immuno-oncology. And so earlier this year, we took that cancer research and tumor profiling into the clinical setting, and we launched what we call our ACE Cancer Plus test. And that really is a medical test that's designed for molecular profiling of a tumor. So what I do and my job is oftentimes I'm out in the field talking to potential clients about this test as well as about our exome sequencing. But most of the time, the people we talk to with this particular test are going to be oncologists and pathologists. It's started to become a little bit of a more interesting topic for genetic counselors, as some of you are probably getting called by oncologists, or maybe you're working with oncologists and are sort of being tasked with choosing labs for tumor testing. And so we thought that this would be a really good opportunity at NSGC to really start talking about tumor profiling. And so the approved learning objectives are listed here: defining conditions and logistical considerations for tumor testing, reviewing implications of those results, examining challenges that are associated with tumor testing, and hearing about one patient's experience. As I mentioned earlier, we're going to do this in 3 sections. I'm going to take the first section, which is an overview of tumor profiling, more about what it is, who orders it, and why. Then I'm going to turn it over to my coworker, Erin, and she's going to walk us through some of the key challenges that we're facing, particularly in the lab with tumor profiling. And then last but certainly not least, we're going to turn it over to our colleague and friend, Luna, who's going to give us a little bit more of a personal perspective about her experience with this type of testing. So before we really go into detail, I always think it's nice to think about where we've come from so we can really appreciate where we are today with cancer treatment. And cancer treatment has really come a long ways, all the way from back in 3000 BC to surgery by cauterization, which does not sound good at all, to where we are now with the advent in 2011 of talking more about precision medicine. Even though there were targeted therapies even in the 90s, precision medicine really came about a little bit more into mainstream in 2011 up until today. So what exactly is precision medicine? Of course, there's a couple of different ways that this term is used. Some people say precision medicine, some say personalized medicine. And again, this has really been a focus over the last few years, and not just in the cancer setting. This has been a focus in many different areas of medicine. And currently, those 2 terms are really used more interchangeably. The idea behind them is that precision medicine is really thought to be more of a technology-driven and participant-centered approach. The thought behind it is precision medicine is really the the drive of it is identifying specific mutations in a person's DNA that might be unique to them or might be unique to a specific population, that are going to aid in determining or fine-tuning a specific treatment. Either for cancer, it might provide specific information about medications, or so on and so forth. So I can't talk about precision medicine without showing the president. Of course, it's well known that any celebrity or political figure is going to have a huge voice in some of these topics, and of course that's no better exemplified in this particular setting by President Obama's really commitment to precision medicine. And of course, he talked about this in his State of the Union address in 2015. And this is just one of the statements from that particular conversation. And of course, tailored treatments for cancer were already underway by that time, but his precision medicine initiative really propelled that more into the mainstream. And now precision medicine is a topic that's really sort of commonly thought about and commonly understood, not just among those of us in the medical profession, but in the general population. So just a little bit about what tumor profiling is. A pretty general definition is that tumor profiling is molecular characterization of a tumor in an effort to guide treatment. The ultimate goal of tumor profiling is to analyze the genetic information in cancer cells, not the individual patient cells or the germline. And so this is a very different topic, of course, for genetic counselors, because this isn't a germline test. That's not the purpose of this test. It's really to look at the tumor itself. There are a number of tumor types for which tumor profiling is done. There certainly are, of course, right now there aren't any restrictions, unless it's a restriction by the lab and what test the lab is offering in terms of the type of tumor that can be tested. Most commonly, what we see is testing for lung cancer, colon cancer, and melanoma. And that's because there just happens to be more treatments right now that are available for those types of cancers. There are guidelines and recommendations that have been published by some professional groups. Of course, ASCO is one that you guys will be familiar with, and NCCN, and some of these other ones as well. In terms of an overview with tumor profiling, keep in mind that for this talk, we're talking about NGS-based tumor profiling. But even in that realm, there's a lot of variability on the type of test, the type of variants that are assessed, and the method of testing. And so in terms of the platforms themselves, custom panels are really going to be the most commonly used. And custom panels, as you'd imagine, are going to be anywhere between maybe a few dozen genes to a few hundred genes. And even in that area, the number of genes aren't going to be standardized. So you can think about this as any sort of germline panel that you might be ordering from various labs. The genes on those panels are going to be different too. Same thing with tumor profiling. Another thing to think about is that the number of genes that are on your panel is also going to sort of, in some ways, dictate the sensitivity of those panels too. So you can imagine that if you've got hundreds of genes on a panel, the genomic footprint of that panel is going to be more broad, and your depth of coverage might be a little bit less for each individual gene. On the other side, if you're looking at a few dozen or a small number of genes, that genomic footprint for sequencing is going to be much less, and your depth of coverage may be higher. And that's a really important concept to just know about in the cancer setting. Of course, it's important clinically, but it's really, really important when you're looking at a tumor with a lot of heterogeneity, and Aaron's going to talk about that later. The types of variants that you're looking at, or of course, before I move on, I should also say exome and genome sequencing isn't as commonly used in this setting. It probably will be over time, but as you would imagine, that's going to be both of them much more broad tests, much less specific, and much less sensitive. So right now, tumor profiling is really panels. That's really sort of where things are right now. So the variants that are assessed are going to be different depending on the laboratory and the type of tests that they're doing. Most of the time, you're always going to have SNVs and indels that are assessed by this type of testing. And some of the labs are going to offer copy number analysis as well as fusion detection. It really just depends. And fusion detection in particular is oftentimes by labs really reserved for some of the hematological malignancies. Of course, gene fusions are really common in those cancers, such as the BCR-ABL fusion. But there are some gene fusions that are really common in solid tumors as well. For example, the EML4 ALK fusion is seen in about 4% of individuals with lung cancer. So it's important to look at fusions, but again, it really just depends on the lab and the testing. And these are important things to think about as a genetic counselor if you're choosing a lab, to look at the types of variants that might be assessed by each individual laboratory. Finally, the testing methods are also going to vary. Of course, DNA is going to be the standard. Most labs are going to be testing at least with DNA. Some labs will also incorporate RNA sequencing into that analysis, and the main purpose for RNA sequencing is to further increase sensitivity to detect fusion events. And so again, that's just one other important thing to consider. Finally, some labs are going to look at tumor only, and that's really, I would say, the norm right now is looking only at a tumor, but there are some labs that are starting to encourage or even require sending in a matched normal, either by blood or saliva. And again, Aaron's going to talk about this later, but there's some pros and cons with both of those methods. In general, tumor only or tumor normal can both give you good sensitivity to detect variants, but when you're looking at a tumor only, using something called a proxy normal is really going to help to sort of reduce some of the false positives that you're getting if you're only looking at a tumor sample itself. Okay, so how does all this testing help your patient? Right now, I would say there's about 4 main reasons that tumor profiling is used, and certainly there will be more over time. 1/5 reason that we're not going into today is, of course, research. But the top 4: treatment decisions, access to clinical trials, prognostic indicators, and use as a diagnostic tool in and of itself are really the main reasons that tumor profiling is used right now in the clinic. And so what I'll do for the rest of my time is talk a little bit about each one of these. In terms of treatment decisions, this is really the primary reason that tumor profiling is done in the first place. The science behind it is that alterations in genes encoding cellular signaling molecules, such as protein kinases, can result in cancer. And so you can develop drugs that can really target these altered kinases in an effort to fight cancer. So you don't want to give every single patient every single drug that's going to fight these altered kinases. What you really want to be able to do is to be able to look at that patient's tumor to say, are there certain mutations or variants that are in that one patient's tumor where they might benefit from that specific therapy over and above the person beside them who has that same cancer but doesn't have that variant in that tumor. And so there's a number of FDA therapies that are available right now. And so this figure on the right is just sort of showing you how that's changed over the past few years. And if you're looking at it over about a 10-year span, there's been quite a few drugs that have been introduced into the market over that time. In green, what you're looking at are new drug approvals, and then in orange, expanded indications for drugs that are already available. So just to show this a little bit in more detail, this is an example to illustrate this concept, looking at MEK and the MAPK, or mitogen activated protein kinase pathway. So MEK is frequently activated or inactivated in a number of cancers, and alterations in this particular pathway can lead to cell proliferation. So what's happening is that pharmaceutical companies are developing drugs that are targeting these pathways. They're called MEK inhibitors, and those are there to fight cancer that's caused by variants in this particular pathway. This is taking just a really small snapshot from one of our sample reports showing where we found an FDA-approved therapy in a patient who had melanoma. And so this mutation probably is pretty common to you guys. It's the BRAF V600K missense variant that's commonly seen in melanoma. And in this particular case, what you see here is that there is an FDA-approved therapy for this particular cancer for this patient tumor type. I'm not going to pronounce these, but there's more than one therapy that's available for BRAF V600E or K variants. And so this is a really, really great example to show that for patients with melanoma, again, this is a commonly used technology for melanoma, that there certainly are FDA-approved therapies that would be available in that case. Most of the time, we are not finding FDA-approved therapies. There's just not as many of them available. And so the second category that we really think about tumor profiling for is for access to clinical trials. And so there's a number of clinical trials as well that are actively underway, looking at patients with particular cancers or particular genomic results to enroll those patients into a clinical trial. And so a couple of weeks ago, I just went on the clinicaltrials.gov website and did a quick search using keywords targeted therapies and cancer. And this is what I came up with here. This is close to 500 clinical trials that are available right now. Some of them are actively recruiting, some of them may not be. And of course, clinical trials are a little bit different than FDA-approved therapies. There's logistical concerns with whether or not a patient might be able to fit into a clinical trial. Sometimes it may be on the other side of the country, it may be very expensive. There's a number of things that have to go into account to help determine whether that might be appropriate for your particular patient. Again, another snapshot from one of our sample reports, another example with a patient with melanoma, where we found a TP53 variant. And again, you guys are familiar with this gene, but it is commonly mutated in a number of different cancers. And so it's not uncommon to find a P53 variant in a patient with cancer. And in this particular case, there are not any FDA-approved therapies right now that have been approved for patients with mutations in P53 in their tumor. There are a number of clinical trials, however. And so that's what you're looking at here is no FDA-approved therapies, but certainly access to clinical trials. And we try to list those out in a clinical report to show various clinical trials that might be available. And so what you're looking at, again, are just snapshots from our report of some of the clinical trials that are available. But in general, you should expect to see more than one clinical trial for a certain variant or a certain gene, as opposed to an FDA-approved therapy, for example. Third category is using tumor profiling as a prognostic indicator. And so again, most tumor profiling is going to be looking at FDA-approved therapies and access to clinical trials. I would say this is a much lesser known category for which this testing is being used, but things are changing. If you think about a prognostic indicator in the general setting for cancer, in general, those are going to be characteristics that are going to correlate with survival, either an increased chance of survival or a decreased chance. And traditional methods of prognostic indicators are going to be familiar to everyone here, such as lymph node diffusion, tumor sizing and grading, and then of course a really common one is hormone receptor status. So we all know that particularly in breast cancer, for example, someone with an ER-positive breast cancer is going to be more likely to have a more favorable prognosis than, say, someone with an estrogen-negative breast cancer. So molecular indicators, similarly, are starting to be used for this type of sort of prognostic indication and are becoming more helpful, but there's a lot more data that's needed in this area. Just a couple of examples that we've come across. For example, here, IDH1 and patients with glioblastoma. So there's some data to suggest that patients who have glioblastoma and have a variant in their tumor in IDH1 may have a more favorable prognosis than those with glioblastoma who do not have an IDH1 variant in their tumor. Of course, leukemia and the presence of the BCR-ABL fusion is a really well-known finding in leukemia. And again, this is also a prognostic indicator in terms of being a hallmark of CML, and the presence or absence of this particular fusion event has really been used pretty routinely at this point to determine treatment, as well as predicting things like relapse and response to treatment. Last category, using tumor profiling to help diagnose cancer. And again, this is an area where it's not used as commonly yet, but things will probably change over time, and this may become a little bit more common. The best example right now of using this as a diagnostic tool is, again, the presence of the BCR-ABL fusion and using that as knowledge of it being a hallmark of CML. Another example that is not as commonly used would be in the case of something like a cancer of unknown primary. So tumor profiling is starting to be helpful in this particular area to help look at molecular signatures that might be present in certain types of cancer to really help fine-tune a treatment for someone where we can't identify where the primary site of the cancer is. All right, so that wraps up my session. Now I'm going to turn the difficult part over to Erin to talk about some of the challenges that are associated with this testing.
Thank you, Heather, and good morning. We do have a lot in here, and so I'm going to talk pretty quickly, but we're definitely more than happy to answer questions offline or later by email or anything like that. So I'm going to start at the beginning with challenges that we see with the sample itself, move on to analysis, and then finish up with interpretation and reporting. So just some logistics, as Heather mentioned, we want to test tumor tissue here. And so what we're receiving is a piece of tumor. And it's usually sent to us from pathology following a surgical resection procedure or a diagnostic procedure like a fine needle aspiration. And it's sometimes a fresh frozen sample, but it's most commonly an FFPE sample. And I'm going to come back to that in just a minute. So one of the first things that we need to do when we receive a sample is determine the tumor content. So any particular sample we receive is going to be a mix of both tumor cells and non-tumor cells, normal tissue, almost always. And so we first need to just find out how much tumor is actually in there. And it has a direct impact on the assay sensitivity, because the more tumor content you actually have, the greater the lab's ability is to detect variants that are present at low allele fractions. You could have a variant allele that's present maybe in only 10% of the tumor, and if only 20% of your sample is tumor, that variant is going to be a very, very small percentage and possibly not going to be detected. And some of these low allele variants that are present at low allele fractions can have really significant clinical relevance. So there's one in EGFR called T790M that actually predicts resistance to certain targeted therapies, and it often develops later in the progression of cancer and might be present at real low percentages, but if it's there, you really need to know about it. And so one of the real challenges comes from the fact that it's kind of difficult to assess the tumor content. It's a pretty straightforward concept. What we want to know is how many tumor cells are there and how many non-tumor cells are there as a percentage. But actually doing that is a little bit complicated. So it's done by pathology, and so you can see here on the right is a H&E stained slide, and that's what they're looking at. And some of those are tumor cells, and some of them are non-tumor cells, and I don't know which are which. But on the left, you can see the cartoon, which I can read. So you can see 5 cells on the left. There's 4 lymphocytes and 1 tumor cell. So that's a 1 in 5, that's a 20% tumor content. But what's really usually done in terms of assessing tumor content is they kind of look at how much space the tumor cells take up. And so you could look at that same cartoon and say, well, that tumor is taking up, 50, 60, 70% of that space, which is really not an accurate assessment. So another method is sometimes used, and it's by counting nuclei, so actually just sort of counting individual cells. But it also has some issues with accuracy. The larger the cell, the less likelihood when you're taking a slice that the nuclei is going to be contained in that particular slice. So it has some problems as well, and they're actually working on some computer imaging techniques, like basically taking a snapshot and the computer will tell you what the tumor content is. So stay tuned for that. And in terms of the tumor content, it's important that we have an accurate assessment of it, but really what's most important is that it really just be as high as possible for the analysis. And so some labs are actually introducing macro dissection procedures, which is where they kind of look at the section and then find out where most of the tumor is and cut that out and use that for the analysis. But even if you have a nice, healthy tumor content, you are sometimes going to run into issues with the quality or quantity of your DNA, and this comes back to our sample type here. So in terms of DNA sequencing, fresh frozen samples are probably best. They are not what we usually receive. And so many of you, I'm sure, are familiar with the issues with FFPE samples in terms of DNA testing, but just a quick review. So FFPE stands for formalin fixed paraffin embedded. And formalin is a chemical that can actually introduce base pair changes in the DNA sequence, and the fixation process can lead to DNA fragmentation. So this method was not designed with DNA testing in mind. And there are actually different factors that can affect the effects that are seen. So we, even at Personalis, we actually study that. So what are the best fixation methods, the temperature and the time in chemical, and there are efforts to kind of communicate that with specific guidelines to the pathology community and kind of tighten that up. And in the meantime, any lab that is receiving FFPE samples really needs to have good, robust QC metrics looking out for issues with the quality or the quantity of the DNA prior to the analysis. So another issue that we see with the sample itself has to do with really just kind of the biology of cancer, and that is tumor heterogeneity. And tumor heterogeneity describes the fact that not all cells of a cancer are identical from a genetic standpoint. And that was really pretty clearly illustrated back in 2012 by this group, Grillinger et al., and they had patients with metastatic renal carcinoma. And they took multiple samples from the primary tumor and multiple samples from the metastasis, and at different time points. So they had spatially and temporally separated samples, and they ran a genetic analysis on that. And what they found is very, very complicated. I know you can't read this. Don't worry about it. I'm just going to show you the main points here. So on the right-hand side are all of the different samples, and these are the results from one patient. So this one patient, there were 12 different tumor samples taken. And across the top vertically are all of the different genes in which variants were found in their analysis. And so what they found was that of all the variants, only 31% over here on the left were common to all of the samples. So the gray boxes represent that the variant was present in that sample. So you can see most of those are gray, and they were common to all of the samples. There was a significant difference then in the variant results between primary tumor samples and the metastasis samples. And so of all the variants discovered, 31% were common to all. So when we're doing this sort of test, we of course have one sample from one source at one point in time. And what tumor heterogeneity tells us is that it's possible you could get different results for the same patient depending on where the sample comes from. Thank you. Now, some caveats are that this was a whole exome analysis, so this is really a research-based protocol. Many of the genes in which they found variants are, probably wouldn't be considered to be clinically relevant or actionable in terms of cancer care. And many of the sort of known pathogenic, clinically relevant driver mutations in cancer are more likely to be common to both a primary and a metastasis. However, tumor heterogeneity is real, and it's something that really has to be kept in mind on the lab side and for you in the clinic. So, which takes us right into our analysis. So, as Heather mentioned, what we're doing here is looking for variants that are unique to the tumor tissue and that really have kind of caused that tumor to grow and that potentially are targetable or treatable. And when we're getting that sample, there's a whole lot of non-tumor cells in there as well, and we really don't want to know the DNA sort of just variant changes that are in the germline sample or in the normal tissue sample. And focusing in on what we really are looking for can be like looking for a needle in a haystack. It can be really difficult. So there's a couple different ways that this is handled. So Heather mentioned using a matched normal sample, and that is just a germline sample from the patient, a blood sample or a buccal sample. And so it provides a germline source of DNA. It can be run alongside the tumor sample in the same analysis. And what that allows is for us to control for any assay-specific artifacts that can come up. You can actually have variants that are introduced in the testing process itself, as well as it allows us to subtract from the total results all of the non-pathogenic, non-clinically relevant germline variants that's present in that patient. And so that's a pretty good way to do it. However, a matched normal sample is not always available. And so if you have a tumor-only sample, you can use bioinformatics, information from population databases in terms of common germline variants that are out there, and then subtract that out from your total results. And so Jones and others last year published a comparison of these two methods. And I know that this is pretty hard to read, but I think maybe you can see the numbers here. So on the left-hand side is their results from doing a tumor-matched normal. And on the right-hand side is their tumor-only analysis with the same samples. And they ran both a whole exome and a targeted gene panel. With the whole exome using a tumor-matched normal, they found on average 135 variants per sample. And using a targeted gene panel, I think it was 111 genes, they found on average 4.34 variants per sample. So these are sort of your true positives, only present in the tumor tissue, really what you want to be looking for. And when you're doing this method, you would have bioinformatic filters to make sure that you're not somehow removing a germline pathogenic variant, because of course that would be very, very important information to have. So using the same samples, running them on the same assay, but just using some information, just bioinformatics to subtract out the germline variants, they came up with 382 variants per sample on average on the whole exome, so significantly more, and 6.3 on the targeted gene panel. So these are kind of, they call them false positives. These are just really, noise in your results that aren't relevant and really not what you want to be focusing on or reporting. So it would seem that, tumor matched normal is definitely a superior method, but it has some challenges as well. So there are logistical considerations and complications in terms of collecting that matched normal sample. These are often samples that have sent out from pathology, months after the procedure has been performed, the patient's not in clinic, getting them to go and get a blood draw, it can be very difficult sometimes. You're basically not quite doubling your assay. You're running 2 samples instead of 1, so it's expensive and it's time consuming. And then of course, I hope we're all thinking about the ethical considerations. So you're now talking about doing germline testing on a patient. And so there's really serious, consent issues that would need to be looked at and other things there. So, and many of these patients are not meeting with genetic counselors. So, but of course, with the tumor-only analysis, as we just saw, there's really too many of the non-somatic, non-tumor variants that come up and that can lead to just really inaccurate reporting. So Heather mentioned a proxy normal, which is basically a non-matched normal sample that we have in the lab. Sometimes it's a pool of multiple samples, and we run that alongside the tumor at the same time. And that really helps control for any of those assay-specific artifacts. Germline variants that are common to both, common germline variants are going to be subtracted out. And then we would have to deal with that patient's sort of private non-pathogenic germline variants as well, but with using a much more robust bioinformatic pipeline than what is used in the paper data that I showed you, and with really comprehensive filtering. At Personalis, we have found that you can really come close to, maybe not quite match, but really approach the specificity that you get with using a tumor-matched normal and without the complications of actually collecting a germline sample for that patient. So that brings us into interpretation and reporting. And this is where things really start to become a challenge for you in the clinic. And part of that is because there's not a lot of shared terminology. The reports go by a lot of different names. I think my favorite is the molecular intelligence summary. Very lofty. So I tend to say clinically relevant. I think that kind of captures everything. Not all of them are actionable. I guess maybe you could stretch it, but so clinically relevant. And Heather kind of touched on this, we therapeutic target or resistance to a therapeutic agent, either FDA-approved or investigational, prognostic or diagnostic information. And there are some that are just totally well-known, very well characterized, such as the BRAF V600E or K or a KRAS G12C. But we can also determine clinical relevance from variants that maybe have the same effect as one of those variants. So for example, what we know about the V600E variant in BRAF is that it causes activation of the protein kinase product, and the prescribed therapy is a kinase inhibitor. So we might come across a variant that is not well known, but there's evidence in the literature that it also has an activating effect on BRAF, and so we can sort of say, well, that's, it would make sense to also use the same protein kinase inhibitor therapy. And so we look at that activating or inactivating, and you might have it in a different gene. An inactivating variant might have the same, also have clinical relevance, particularly in tumor suppressor genes. So of course, we have variants of uncertain significance. And the interesting thing about somatic tumor profiling is that you can have the exact same variant have different clinical relevance in different tumor types. So you might have a variant that has clinical relevance in one tumor type and be a variant of uncertain significance in a different tumor type. So a little different than we're used to with germline testing. And that's particularly true when you're looking at solid tumors versus hematologic cancers. Now, again, we look at that activating or inactivating characterization. And going back to our BRAF example, if we were to come across an inactivating variant in BRAF, such as a frame shift or nonsense mutation, what we know about BRAF is the clinical relevance comes from activation. So an inactivating variant is likely going to be a variant of uncertain significance because it just doesn't have the same clinically relevant effect. And these are variably reported, meaning that most labs list them at least, but some include a little bit more information. There's not necessarily strict criteria about how these need to be reported. So likely benign variants are germline variants that are not pathogenic, not clinically relevant, just your germline variation that's in there, that are, of course, we're going to come across because we're happen to also be testing normal cells as well. And that is suggested to us by having a high allele fraction. So if you have a variant that's in the germline, it's likely going to be pretty high, 50% heterozygous or maybe even 100% homozygous variant. But that is going to vary with your tumor content. So that's not something we can totally hang our hat on. We also look, of course, at population databases like EXAC and others, if it's common in the population, and then basically lacking any evidence that it's pathogenic or having clinical relevance would push that into a likely benign category. And those are really variably reported, meaning that many labs don't include it at all on their reports. So probably why you got up so early today and are here is the issue that is really on a lot of people's mind here, which is the germline pathogenic variant. And in terms of, from our perspective in the lab and running these tests, it's a rare thing. Most of these patients do not carry germline pathogenic variants, but of course in the genetic counseling world, that's what you do, and that's what you're dealing with. So I don't have time to really do this topic justice today. There's a session tomorrow that I think is going to go into a lot more detail, not with us, but another group. I think it looks very good. And it was the topic of the short course earlier this week, and I think it needs to be a topic of discussion going forward for sure, but I'm just going to kind of touch on a couple key things to know when you're looking at some of these reports. So a really important thing that I'm sure you realize, but I just want to very clearly state, is that a negative report from a somatic tumor profile does not mean that that patient does not carry a germline variant, that a germline variant is absent for that patient. So if you have a patient who you're suspecting has a hereditary cancer syndrome, but they've had somatic tumor profiling and it's negative for the gene that you're worried about, it doesn't mean that they don't still need germline testing. So there's a couple different reasons for that. Heather outlined a lot of the variability that's between different labs and institutions. The gene you're thinking of may not even be on the panel, or it may be that the coverage of that gene for that assay is not sufficient to detect all pathogenic variants, or that the variant type can't be detected by that particular assay. So there's a few different reasons why a negative result really doesn't mean a negative in terms of germline testing. And the other thing in terms of tumor only or tumor proxy normal analysis, germline origin cannot be definitively determined. There are clues which make us, suspicious for that. The gene and tumor type kind of matching up, the having a high allele fraction, reports in ClinVar, and of course, sort of well-characterized known pathogenic germline variants in hereditary cancer genes are going to be reported, but outside of the, founder mutations and things like that, but outside of those, and even then, it can't be definitively determined to be germline for that patient. But many times we don't have that kind of specific information, and so there's a lot of different things we'd have to look at. But the bottom line is that without testing a germline source of DNA, you cannot know for sure if that patient carries a germline variant. So use your pedigree. If you think your patient needs germline testing, proceed with germline testing. I think you all know this, but it is something that I think that this particular area is really ripe for confusion and misunderstanding in the broader medical community and in the health insurance community, in terms of really understanding what type of genetic testing has happened or is going to happen and what the results can tell us and what they can't tell us. And I think that as genetic counselors, we can be very helpful in that in terms of educating our colleagues. And then just unfortunately, really quickly and last, really just kind of a thought-provoking thing here. I talked about, even in the absence of doing testing a germline sample, the possibility that we might be suspicious about a germline variant, and we might put that on the report. This patient might consider going and talking to a genetic counselor and having germline testing. And even that information can be really distressing for a patient. They're sick, they have cancer, they're dealing with that, and then on top of that, you're scaring them by saying you need to talk to a genetic counselor. So this particular area of testing has really lived in the oncology and pathology space right now. And I think that as genetic counselors, we need to kind of insert ourselves into that conversation and really remind everybody about what the serious informed consent issues that are at stake here and the ethical considerations, and kind of reinforce the idea that the right to not know something and to decline information is just as valid for these patients as to learn something from testing. So That's all I had today. Just to wrap up, we talked about the way that tumor purity content affects the assay sensitivity, how FFPE samples can complicate matters, and tumor heterogeneity is a complicating factor as well. How to focus really in on the variants that we want to know about in our analysis, and then the factors that go into our variant classification and a lot of the big complications that go along with the germline variant issue. So I'm going to wrap up here, and I'm really, really happy to be turning this over to Luna Okada, who is a genetic counselor, and she's also a patient, and she's going to really help us take this conversation into a much more personal perspective for us.
Thanks, Erin. Good morning. Heather and Erin asked me to tell you my story, so thank you for being here. These are my disclosures. I'm going to cut out a few things in the interest of time. Probably the most important thing on this slide is that I've never had a sample sent to Personalis, and in my story you'll understand why that's an important point. But I do work for both Amita Health in Illinois and Insight Medical Genetics. I'll try. I'm not very good at this. So my story starts here. In December of 2012, my family and I went to Machu Picchu, and it was my 54th birthday on December 7th, and I was probably feeling as strong and as healthy as I ever had because I trained to get there. 1 week later, and 2 days after returning from Peru, I was in an ER with pretty significant abdominal pain and nausea, and I was so certain that I had brought home a GI bug. And the doctors thought perhaps I had a gallbladder thing going on. So I had some imaging studies, and that's not what they told me. So I had a 3-centimeter lung mass. I had multiple lesions in my liver and my bones, and they told me I had advanced cancer, and they wanted to put me in the hospital to find out where the primary was. So the next 2 days were filled with lots and lots of testing. I had imaging studies. They took lots and lots of blood, including serum tumor markers. I had a liver biopsy. They wanted to confirm the cell type and also do tumor mutation analysis. So I got a lot of doctors. My local oncologist ended up being the doctor that was on call the day I was admitted. I also went for second, third, and fourth opinions to Northwestern, University of Chicago, and eventually I went to the University of Colorado. So my diagnosis is non-small cell adenocarcinoma of the lung. I have stage 4 disease. My initial tumor mutation analysis was negative for mutations in EGFR and ALK, which are somatic tumor genes. And at that time, and based on my demographics, I had an 80 to 85% chance of having a mutation in one of those genes. And I really, really wanted one because there were targeted therapies available, and they were 2 of few that were available in 2012. I need to tell you that I'm a never smoker, and I have no risk factors. I didn't grow up in a smoking home. I've never had a job that exposed me to smoke, like working in a bar when you could smoke in bars. And I have no family history. And it seems really the only risk factor I have is that I have lungs. So I just want to throw out a few facts about lung cancer. It's the #1 cancer killer, and it exceeds breast, ovarian, and prostate cancers combined. About 20% of us are never smokers, and it's the least funded area of cancer research. And those of us in the lung cancer community are pretty certain it's because of the stigma that's associated with our disease, and that's that somehow we deserve our cancer because we smoked. My prognosis was terrible when I was first diagnosed. The median longevity was 8 months, and I really didn't know what that meant. But from the time of diagnosis, 8 months later, 50% of us are alive and 50% of us are dead. My 5-year survival rate in 2012 was about 2%. And now it's about up to 16%, or 17%, which really speaks to the new therapies that are available to us. But 17% is still pretty awful. So shortly after I was diagnosed, I started writing a blog, and at the end of my first blog, I wrote this, and it's a word about being the sick person. It is extremely difficult to be that person. I was watching the people close to me cry for me, and I held my family as they cried for me, and it was just such a difficult time. So not having a diagnosis, I started on a traditional chemotherapy. Not having a mutation. And so I had an implantable port implanted into my chest. I was going to get I got IV chemotherapies 3 times a week. I was on carboplatin, Alimta, and Avastin. And that's the first time I really had like total sticker shock. Chemotherapeutic agents per treatment are extremely expensive. And the first infusion date I had, my oncologist office only had secured insurance pre-approval for 2 of my medications. So I was given the option of just putting it on my credit card, $7,800, and then waiting for insurance to reimburse me if they were going to approve it. Or I could wait for a pre-approval and then come back a second day for another infusion. And my husband really wanted me to just get it. And I didn't want to do that because I didn't want to deplete our savings, and I didn't want to leave my family with any kind of debt if I was going to be dead in a year. So my husband and I got into this sort of hissing disagreement in the chemotherapy room because patients are only separated by curtains. So we're hissing at each other, and he's saying things like, please, and I'm saying no. And eventually he said to me, because he knows me so well, he said, what if we put it on the Costco American Express card and we'll get cash back? And that's the only reason I agreed to doing it that day. So I got 2 rounds. I had lots of nausea, vomiting, the traditional chemotherapeutic stuff, side effects. I had weight loss, lots of mental fogginess in the beginning, but interestingly, no hair loss. So I had follow-up CT scans, and despite going through all of that, I still had disease progression. So we had to come up with a plan B, and right about that time, there was a new targetable mutation called ROS1 that was being described. I had a 1% chance of having that. And all of us know what 1% means to different people. And at that time, in my state of mind, I was so focused on the 99% chance I would not be lucky. My husband really wanted me to do this. My doctor, my oncologist really wanted me to have pan-cancer testing. And I wasn't sure I wanted to go through all of that because I wasn't sure that my insurance would pay for another round of mutation analysis. Plus, we needed to do another liver biopsy because they had used up all of my sample in the first testing. And there was a complication, and that is Avastin posed a bleeding risk. And so I had to wait a 28-day washout period before I could get my second liver biopsy. And for that month, nobody was comfortable with me doing nothing. So I had a second-line IV chemotherapy called docetaxel. And docetaxel kicked my bottom. It was, I was told that I should expect to feel like I was at the height of the flu for 7 to 10 days, and that's exactly what happened. So along with the nausea, the vomiting, and all of that, I had a fever. My hair started to fall out a couple days after I got my docetaxel, and I decided to get my head clipped because I didn't want long pieces of hair falling out. So when all the short pieces fell out, my head looked a lot like that cue ball. So I got a wig, and for insurance purposes, my oncologist had to write a prescription for cranial prosthesis, which was one of few things I found funny back then. So I had a second liver biopsy. My oncologist had the sample split and sent to 2 different labs. Lab A, he sent it to because the turnaround time for ROS1 was only 7 to 10 days. And the other sample went to Lab B because the turnaround time for pan-cancer testing was about 4 weeks, and they could not expedite ROS1. And the good news is I came back positive for ROS1 in Lab A. So as soon as we figured out the insurance part of it, I started on an oral chemotherapeutic agent called crizotinib. It's a Pfizer product. It was not yet FDA approved at the time, so I was using it off-label. And it cost $15,000 a month. I don't make that much. So insurance is good to have. I was on that for about 3 weeks, and then the results from the pan-cancer testing came back, and it said this, that I was negative for ROS1. So I felt like we were treating the wrong thing, to the tune of $15,000 a month, and I didn't know what to do. So I cried, and I cried. My oncologist, on the other hand, he called both lab directors. The lab director at Lab A immediately agreed to repeat testing. The lab director at Lab B was pretty sure that we had sent him normal liver tissue and not tumor tissue, so he didn't see a need to repeat testing. I committed myself to reading every single word and every single page of the lab reports that came from both labs. And I discovered something, and that is that ROS1 testing at Lab B was a send out to a third lab, Lab C. So I called my oncologist, who called the director of Lab C, who was very bothered by the discordant results. She repeated the testing right away and issued an amended report saying that I was positive for a ROS1 rearrangement. So there are a lot of what-ifs in my story, and what if my oncologist and my husband didn't pressure me into testing further? What if my oncologist didn't split that sample and it all went to Lab B? And what if I didn't read that my sample was sent to Lab C? And what if the lab director at Lab C wasn't bothered by the discordant results as the director at Lab B was not? And the answer to all of those questions is that I probably would never have started crizotinib or stayed on it. I probably would not have done very well and probably wouldn't be here today. I want to say a word about being an undetected addict. I had a fair amount of pain, and I was taking ibuprofen, but I couldn't stay on ibuprofen because I wanted to get this second liver biopsy, and that's a bleeding risk. So I got a prescription for OxyContin, and I was pretty nervous about taking it, knowing that there's a high addiction rate. But I really didn't have an alternative because I was still trying to work and do the best I could in terms of living. And as soon as I started a crizotinib, I dramatically became better, and the pain went away. So I wanted to get off of it, but I couldn't wean off by myself. I had lots of withdrawal symptoms, including sweating and shaking. I truly felt like a junkie. And I had extreme anxiety and panic attacks, which I'd never experienced before. I turned to my oncologist for help, and there's an incredible lack of weaning experience among prescribing oncologists, largely because once a patient gets on OxyContin, they almost never have to get off of it or never want to get off of it. I ended up turning to a childhood friend of mine that's a PharmD, and he wrote a weaning schedule for me. And he checked in with me weekly, and we made these schedule adjustments. And despite his intensive help, it took me nearly 5 months to get off of OxyContin. So my current status is that I have stable disease. I continue to take crizotinib twice a day. I've been on it for nearly 44 months. The clinical trial reported benefit for only 18 months. And no one knows why there's some of us that are getting long-term benefit and others are only seeing a few months of benefit. The side effects are minimal or manageable. They were much worse in the very beginning, and then I kind of got used to things. Although recently, I've been diagnosed with an ulcer that's secondary to crizotinib because it's such a corrosive medication, and it seems like a lot of people that are on it long-term are also experiencing GI issues. There is still no cure for me, and brain mets are likely in my future. I have mets in my cervical vertebrae, and crizotinib does not cross the blood-brain barrier. when crizotinib stops working for me, I wrote I may need to enter into a clinical trial, but my guess is I'm going to be desperate enough to want to be in a clinical trial, and so I'll do my best to get into one. My plan for right now, I get serum tumor markers every 2 months, this port is really handy. I get IV bisphosphonates every 3 months for bone mets. I get CT scans every 4 to 6 months, and we track the tumor markers to help me know when to have those. I get brain MRIs every 6 months. I irrationally think that if I keep my head upright and I don't jump around too much, like the tumor cells won't jump into my brain, so I try to keep cognizant of that too. I watch for updates in drug trials, and I'll keep working and playing for as long as I can. I've made a few observations that I thought might be helpful, and there's no science behind any of these, are just me blabbing about what I've observed. And that is that patients who know the most live the longest. Patients that seem to travel the furthest for care or consultation also live the longest. And both of those are a function of level of education and access to resources. It's very clear to me that everybody with the same disease does not get the same care. Patients who are well integrated into their communities tend to weather treatments better. Younger oncologists are far more likely to order genetic testing. And it's just sort of, in my experience, it's just been, my recommendation is to look for a doctor around age 40, because those are the ones that have helped me the most. More and more survivors with stage 4 disease are becoming chronic illness patients. And for now, because of research, I have lots of reasons to be optimistic. Thank you for listening to my story.
I'm sorry. Thank you, Luna. That was amazing. And of course, we're over time, but if you guys do have questions, we're happy to stick around. We're also at a booth today during the exhibit theater from 11 to 3, so you can feel free to pop in over there and ask questions too. I want to say it's number 409. Thanks, everyone.